right. So we're so excited to welcome Erin McClain. She is the Assistant Director and Research Associate at UNC Collaborative for Maternal and Infant Health. And today she's going to talk to us about the Dignity Act and postpartum and incarcerated women's health. So with that, I'm going to turn our community of practice over to Erin.
Thank you. I am hopefully going to be able to share my slides. Suzanne, do you want to pull them up? For some reason, they're not showing as an option for me. I'm sorry, y'all.
Go ahead and try one more time. I just changed.
All right, it allowed us to have a few more people join us. Welcome, everyone. We're glad you're here.
See, my delay is, here we go.
Perfect.
All right. And I always have trouble with this one. Slideshow. Beginning. All right. Are y'all seeing the slides?
Looks great.
Awesome. So I am going to, as Suzanne said, folks are going to monitor the chat. I'm also going to take pauses and would love for you to come off mute and just ask questions. If you have any questions along the way, I'm happy to answer them. We are lucky enough to also have Velma Taramino in our group who works with us on this work around incarcerated women's health. So if I can't answer it, Velma probably can. But as Suzanne said, I'm Erin McClain. I'm with the Collaborative for Maternal and Infant Health. And one of the things that we are working on is improving care for pregnant people, postpartum people who are in county jails. And de facto, we end up working with the North Carolina Correctional Institute for Women, which is the prison in Raleigh. And we'll talk about more of that later. Sorry, y'all. So the objectives today are to summarize some common characteristics of incarcerated women that might affect their interaction with the healthcare system, understand what the Dignity Act for women who are incarcerated is about, and what are the implications, for patient care for women that you may be caring for. Think through some of the disparities in care for incarcerated women and think about how they can be addressed through trauma-informed care and addressing stigma, and demonstrate understanding of the need to address COVID-19 vaccination among incarcerated pregnant and postpartum people. I think, the ACOG guidelines are really clear. Healthcare for incarcerated people should be provided in accordance with the same guidelines and recommendations for those who are not incarcerated, but with attention to increased risk of infectious disease, mental health conditions, other conditions common to incarcerated folks. Really quickly, I want to go through what the difference is between a prison and a jail. Prisons are under state or federal jurisdiction. We have one federal facility that accepts women, but not pregnant women in North Carolina. And then we have several state facilities that accept women, but only one that accepts pregnant women, which is the North Carolina Correctional Institute for Women in Raleigh. It's typically for long-term incarceration, a year or longer after sentencing. The only exception to that is that pregnant people are often sent from local jails. And this includes people who have not been convicted of any crime, right? So these are folks that might be newly arrested, who might be waiting trial, who are unable to make bail, but they are sent as what are called safekeepers to NCCIW so that they can receive medical care. Jails are local facilities under city, district, or county jurisdiction. In North Carolina, we have 100 counties, but 97 of them have jails. Some of the smaller counties work together. 86 of those jails accept women. If a woman is arrested in a county that has a jail that doesn't accept women, she is sent to a neighboring county. These are generally short-term holding facilities. People are there for generally less than 1 year. That's not always true, but it can be. The average length of stay is under 14 days. So often people there are there for really short stays, but the risks and the damage that those short stays can do is pretty mighty. As I said before, folks may be newly arrested, awaiting trial, or awaiting sentencing with an inability to pay bail. We still have money bail in North Carolina, and generally to work with a bail bondsman, you have to be able to put up 10% of that bail amount. And so one of the folks that we work with, Christy Puckett-Williams, who works with the ACLU, was formerly incarcerated during pregnancy, and her bail was $167,000, which would have meant she would have had to have come up with almost $17,000, which is basically impossible. And this happens over and over again to folks who are poor and unable to make bail. They end up staying for much longer than others. There's been a real rise in incarceration of women in the United States since the 80s, since the war on drugs, since the start of minimum sentencing laws. You can see the gray bars are federal prison, blue bars are state prison, and the yellow are jails. North Carolina has pretty much followed that same pattern. On the left here, you can see the number of women in North Carolina jails. It's increased 18-fold between the 1970s and today, and that the number of women in North Carolina's prisons has increased more than 5-fold. A lot of that does have to do with substance use disorders and the rise of the opiate crisis. One thing to remember about women who are incarcerated is that the vast majority are mothers to children under the age of 18. So these are reproductive women. They are often primary caregivers. You see anywhere from 85 to 95%. 86% of them have experienced sexual violence. 32% have a serious mental illness. When you start looking at issues like depression, anxiety, you see that almost all of them have struggled with those mental illness conditions. 82% have a history of substance misuse or dependence. When we look at our folks who are pregnant and incarcerated in North Carolina, it's anywhere from 95 to 97% have either a history of substance use or active substance dependence. And 60% were unemployed prior to arrest. So again, these are folks that are facing a lot of instability, a lot of challenges even before they interact with the carceral system. Our project, North Carolina received about $40 million from CDC to work on COVID health disparities. And we were able to get a tiny portion of this money to work on disparities amongst women who are incarcerated in county jails. One of the first things we did is talk with folks who have lived experience of being pregnant or postpartum in a county jail, especially during COVID. And we plotted out the kind of system that they interacted with and where there were points of intervention. So you can see most folks have some interaction with law enforcement. They then go before a magistrate. Magistrates have lots of power to decide to set bail, decide if folks will be held at all. So that's definitely a point of intervention. People are then put in a holding cell. They have their first court appearance, and it's at that court appearance that if they are not able to afford counsel, a public defender is assigned to them. And then there's subsequent court appearances. We find that pregnant women are often sent for safekeeping, though some are kept in county jails, particularly women in outlying counties, really rural counties. And then we have the delivery of the baby and or release. So there's kind of lots of different places that people can intersect with this system. We felt it was really important to take the opportunity to provide information for justice official resources, for pregnant and postpartum people themselves, defense counsel resources, detention officer training, sample policies for jails, working with medical providers and hospital training to make sure that all the different systems that interact with the carceral system get information about the new dignity law that I'm going to talk about, as well as maternal warning signs during pregnancy, but also particularly during the postpartum period. so that we can improve care for women who are in this system. So the Dignity for Women Who Are Incarcerated Act was enacted on December 1st. So we're just coming up on a year of it being active. It does enhance the care provided to incarcerated pregnant people, as well as women in general. And it applies to all jails and prisons in North Carolina. Unfortunately, no funding accompanied this bill. And so it's largely been our group, folks at the Women's Health Branch, and other places that are trying to get the word out across the state. You can access the full text of the Dignity for Women Who Are Incarcerated Act on our website, which is incarceratedwomenshealth.org. And a lot of the resources that I'll talk about today are available there. Some provisions that are relevant to y'all are the prohibition of restraints. So that's any kind of shackling during the 2nd and 3rd trimester through 6 weeks postpartum. There's a prohibition of any body cavity searches during pregnancy or postpartum. Prenatal labor and delivery care is provided at no cost. So prior to this, women had to pay for prenatal care. There's newborn bonding time put in this act, as well as nutrition guidelines, and adequate nutrition and hygiene products have to be provided by the jail or prison. Prior to this act being on the books, the only thing that was in statute about care for pregnant postpartum women is that they should receive, quote, standard of care. It was one sentence, and that was it. And we had no guidelines around shackling or any of these other issues. So in terms of restraints, so this would include leg restraints, handcuffs or other wrist restraints, restraints that are connected to others, waist shackles. So during the 2nd and 3rd trimester of pregnancy through 6 weeks postpartum, folks may not be shackled. The only exception to this, there's two. One is wrist restraints held in front of the body may be used when a person is in transport outside the correctional facility. And if there's a severe security risk, in the security risk exception, there is a written report that's required to be filed within 5 days with either the warden if it's a prison setting, or with the sheriff or jail administrator if it's a jail setting. So restraints are never allowed during labor or suspected labor. And that is really important. It is now outlawed. Body cavity searches are prohibited anytime during pregnancy. So not just 2nd and 3rd trimester, but anytime during pregnancy through 6 weeks postpartum by corrections personnel. If there are these rare instances where there is suspicion of contraband, an exam may be done by a qualified medical person, but the corrections officer would still need to document that reason within 5 days, again, to the warden or sheriff. At the prison level, the warden, and at the county level, the sheriff has to compile a monthly report of all of these exceptions, and it is supposed to be available. It is not necessarily happening yet, but that is what is supposed to be happening. Following the delivery, and this is whether somebody who's in county jail or prison, the newborn shall be permitted to remain with the birthing person while in the hospital. So that includes rooming in. She should be able to hold her baby at any time she likes. She should be able to nurse them, pump for them, whatever she would like to do, she should be able to do. The only exception to this would be if there are severe health and safety concerns by the medical provider, but again, that should be incredibly rare. Prenatal labor and delivery care have to be provided at no cost. Prior to this, people had to pay anywhere from $3 to $12 to $20 for every appointment that they went to, which meant in reality, most folks did not receive adequate care during pregnancy or postpartum. Prenatal nutrition and supplements have to be provided at no cost. What we heard a lot of prior to this in county facilities in particular was that the guideline was 300 extra calories a day. And so they would provide 3 oranges a day with each meal as the extra. So that's 21 oranges a week, right? Or an extra carton of milk and call it good. And what this says is that it needs to meet dietary guidelines as set out by ACOG. We do know that pregnant women and postpartum folks are being fed a lot of lunch meat, a lot of tuna fish. In the hospital, if folks are delivering, folks have to be allowed to access the full range of hospital meals while they're hospitalized. So just because they only eat at the prison at 4 a.m., 1 p.m., and 7 p.m., that does not have to be the schedule while somebody is hospitalized. They should be treated like any other hospital patient. And postpartum hygiene and sanitary products have to be provided at no cost. Again, prior to this act, that was not happening, which meant pretty dire situations for a lot of women.
Erin, quick question. Yeah. Are they receiving prenatal vitamins, folic acid?
Not generally. In our experience. The exception to this would be at NCCIW. We know the orders are often written for these vitamins and folic acid, but even at NCCIW, it's not always carried out.
And then treatment for hyperemesis?
Again, at NCCIW, where UNC's OBGYNs provide care, we do know that there is some attempt made, but at the jail level, and we can talk about how bad care is at jail levels in general, that is typically not routinely given. I think if it's really extreme, we'll often see some effort made, but most jails would end up transferring somebody to NCCIW if they were that sick. One of the things to just remember about jails is that the health budget comes out of the sheriff's budget. So all healthcare is paid for by the sheriff's department. And what that means is that in most counties, they outsource that care via contract to a private corporation. I think 56 counties use Southern Health Partners. There are other private companies that folks use for, in some counties, they do use the county health department, but that's becoming more and more rare. Health directors are required at the health department level are required to sign off on the medical plan. But it's a really complicated thing because basically the services that are available are what the sheriff's office is able to pay for. So we have some counties that are large, may have more funding, and they may have a nurse there 24/7, right, to respond to urgent medical needs. In a lot of counties, though, you might have an LPN there on Tuesday mornings, and that's pretty much it. And other than that, they're calling 911, which of course, again, they are reluctant to do because that care is coming out of their budget. So, what we often hear too is that if pregnant women are getting close to the end of pregnancy because counties don't want to pick up that cost, they do often transfer as well to NCCIW at the end, even if they've kept that woman in their facility up until then. Substance use treatment is also very hard to come by in county jails, even when there are programs for men available. Often those programs are not available for women, and certainly not geared towards pregnant folks. And what we often find is that people are often undertreated. So if you know, the amount of Suboxone or methadone that the county is providing is often less than the therapeutic guidelines, which is not great for withdrawal or overdose. Some other provisions of the act is that restrictive housing, so that solitary confinement, is prohibited during pregnancy through postpartum. Again, correctional facility must provide nutrition in accordance with prenatal nutrition guidelines. And this goes for all women. Inspections of undressed females by male corrections employees must be limited and can only occur if there is not a female employee available within a reasonable amount of time. This includes men not supervising showering areas, bathroom areas, doing strip searches, things like that. Menstrual products also must be provided at no cost. Again, this was not the case prior to that. And we often found that women, were bleeding through their clothes, did not have access if they couldn't afford it. In state prisons, so this does not apply to jails, but in state prisons, moms have to be held within 250 miles of their infant when possible. And they have to at least twice a week contact visits, which means mom can hold the baby, have to be allowed in lower minimum security facilities. Yeah.
Erin, I just wanted to call out a few things in the chat. So Michelle from Union County noted that they manage the inmate health medical services in Union County, and all of their pregnant inmates get the exact same care as their private patients, as the health department provides prenatal care for the inmates. And then Velma noted that all local jails need to develop a relationship with a local OB obstetrical provider to help with issues that come up, and that they will transfer someone if the local provider makes a recommendation due to being unable to provide specific support. And then Michelle also noted that they continue MAT for pregnant women if they're already in treatment. So we know there are bright spots out there.
That's right. No, and that's awesome. I think, and what we have found in lots of different work that we've done at the center is that the health departments are often providing the Cadillac of care. They're really good at providing comprehensive obstetric care, and often provide some of the most trauma-informed care. So that's great to hear that's happening in Union County. Unfortunately, that's really been a shift away for most counties, which has also contributed to increased use of things like safekeeping. I want to just pause for a second and talk about safekeeping. So one of the things that happens is there's kind of two reasons pregnant women end up in county jails. There's, often substance use related reasons. There can also be probation violations where folks are supposed to be in county jail for 90 days. If they're sent to NCCIW though, what happens is that their hearing date gets pushed off and pushed off and pushed off because there's nobody. It would be on the county to go to Raleigh, get that person, bring them back for their hearing, and then transport them back. And most of the facilities are viciously understaffed right now. They were understaffed before the pandemic, and COVID made it worse. And so what we find is that people who have not been convicted of a crime, or people who are supposed to only be incarcerated for 90 days, end up staying in a carceral setting for 6 months, 9 months, really long stretches of time, when they would, if they had not been pregnant, they would not have been incarcerated for that length of time. So that's just something to keep in mind about safekeeping. If you run into an issue with shackling, both somebody who's pregnant or somebody who's postpartum, there's a couple of things you can do. This often comes up around shackling. It can come up around nutrition. We've heard a lot of times correction officers or detention officers don't want to allow people to eat, when they've just given birth. And so, because it's not on the jail schedule. And so you want to reference the dignity bill. We do know that detention officers have varying levels of knowledge about the dignity bill. It's slowly making its way out there, but it's not fully, certainly people are not up on the latest. If you're a nurse in a hospital setting, you can consult your charge nurse, use the hospital chain of command. If you're in a local health department setting, calling in your program supervisor, you want to ask the guard to call their supervisor and then use the chain of command if not remedied. Something to know at the county level, the sheriff is the ultimate decision maker. In the prison, it's the warden, but at the county level, the sheriff is that ultimate decision maker. And they should be following the law. And you can document suspected incidents. We have a confidential database on incarceratedwomenshealth.org. And this is really just to collect information about counties where they may need more education and support for the correctional staff.
And Erin, there's a question, a really good one in relation to this, which is whose responsibility is it to enforce this bill and get the message out?
So it was The way it was written in the bill is that Department of Public Safety has to provide a training to their staff and then make it available to local facilities. In reality, what that has meant is that they have a training that's available on their local management, on their learning management system, and county level folks can't access it. And like I said, there were no funds put in this bill to support its dissemination or its enforcement. And so one of the things we're doing as part of our project is working with the North Carolina Justice Academy, which trains all of the county level detention folks as well as local law enforcement, and putting the Dignity Act in their training for all detention officers who are new, as well as the yearly update, and also putting information about maternal warning signs in there as well. But yeah, I mean, unfortunately, the way things happen in carceral settings is that until somebody sues, it often isn't enforced. And so we're trying to avoid that by getting the word out as much as possible and hopefully helping people do the right thing up front.
Erin, can I add to that too?
Sure, yeah.
And the responsibility, I mean, to enforce it is just like Erin described. But on the other hand, to me, they're sort of like policing themselves, right? But so the reason we want to spread the information with everyone that's in the obstetrical, landscape is because enforcement is truly going to come from individuals that are seeing the problems out on the field. So if you see somebody who's not following the law, then we want you to engage with them, to let them know that you're, number one, that they're being watched, right? But to formally go up the chain, because that's the only way that we're going to truly make a difference on the ground. So we're sort of like the enforcers, but.
I think, one of the scariest parts about how people are cared for or not cared for in carceral settings is that people often disappear. And one of the unique opportunities in the obstetric setting is that they are having contact with a healthcare provider whose role and responsibility it is to care for their patient, right? And this, for me, this is considered part of caring for your patient, right? Making sure that the law is followed. Thank you guys, those are great questions. Just want to talk about a couple of things in thinking about caring for incarcerated folks, for formerly incarcerated folks. You want to avoid terms like inmate, felon, offender, criminal, drug user, junkie, ex-con. We want to talk about a person who's incarcerated, an incarcerated person, somebody who's awaiting trial, somebody who is formally incarcerated. And most importantly, ask the patient what they would like to be called. I've worked in tobacco cessation for pregnant women and new moms for a long time. And we know that women who use substances during pregnancy and postpartum feel a huge amount of shame already, right? So we don't need to pile on. We need to make sure that we can help them work through any stigma and get the services and care that they need, and that they have a compassionate advocate in you. Also, if you're ending up incarcerated during pregnancy or postpartum, things are not going great in your life, right? And so we really want to move from what's wrong with this person to what's happened with this person. We know that a lot of the folks who end up in carceral settings have had really significant adverse childhood events. The folks at Horizon say that most of their clients often have 9 or 10 adverse childhood events that they came into adulthood with. And what that means is that often these can be difficult folks to take care of, right? If you're giving birth scared and alone, or you're postpartum and you're going to be separated from your baby, you may be irritable, you may be anxious, you may have outbursts of anger, you might have flashbacks or difficulty concentrating, severe difficulty trusting, which makes total sense, feeling a lot of self-blame or guilt or shame, or sometimes these folks can really act disconnected or numb, like they don't care what's happening. Of course, we do know they do care, but they are in a state of emotional shock, right? So with all patients, these are kind of trauma-informed universal precautions, but I think particularly with folks who are incarcerated or formerly incarcerated, you want to be mindful of people in the room. If somebody is delivering or they're there for an appointment, often the correction officer is in the room or two correctional officers are in the room. You can pull the curtain, right? You can talk quietly so that they don't overhear all of their medical information. Whenever you can, you want to protect privacy and modesty. Always ask before touching somebody, right? It's common sense, but we want to make sure, especially in folks who've experienced a lot of trauma, that we're asking them for permission, that we're explaining everything that we're doing, and that there's no surprises, and that we stop immediately whether or not somebody can vocalize their distress, right? So some people, there's fight, flight, or freeze. Some folks who freeze are not able to say stop or no. And so if somebody is visibly distressed and you can tell that they're sweating, or they look uncomfortable, or they've frozen, you want to stop and make sure you're backing up and explaining what's going on. We know in folks who are incarcerated that some of the potential triggers are going to be that separation from the baby, CPS involvement, lack of control in the placement of the baby, anxiety about their recovery, especially in a carceral setting, uncertainty about the future, and then their milk coming in can be a huge trigger. So you want to make sure you're allowing space for the patient to express their fears, their concerns, acknowledge her grief and her loss of control. This is a really hard thing to go through. You want to ensure adequate pain control and patient understanding of the post-birth warning signs, maternal warning signs. We know both from our work listening to people with lived experience, but also there's been several surveys done with correctional health staff in North Carolina and county jails, as well as detention officers in county jails. And from both sides, we've heard that often detention officers and correctional health staff are taught not to believe the people in that setting, right? So not to believe their patients, not to believe the folks who are incarcerated, because they're going to be manipulating them. And so when women had a concerning symptom, they often had to advocate for themselves really stridently and persistently to get anybody to take them seriously and actually help them get care. You want to provide information up front regarding lactation and breast health. A lot of women think that if they are on substance use treatment that they can't breastfeed, and the Academy of Breastfeeding Medicine says that's not the case. There's still value to that baby receiving colostrum, to the mother-infant bonding during that time, even if they're going to be separated. You want to make sure that lactation is there to support them. And you want to be upfront with information about how to, that milk is going to come in, how to deal with engorgement when they have limited access to things like pumps. Most jails will not allow even a manual pump to accompany somebody home. And so how do you deal with engorgement when you really can only use hand expression? What are signs of mastitis or clogged ducts to watch out for? In some cases, you are able to provide information about immediate postpartum long-acting contraception options, particularly something like Nexplanon, which has a pretty low complication rate. I'm sure on this crowd all knows the post-birth warning signs. One of the things to keep in mind is that often women are not allowed to bring anything back into the carceral setting. We are developing materials that the jails will be able to order for free to have on hand, and part of that will be those maternal warning signs in a patient-friendly approach. But another thing that you can do is make sure that you're teaching people both prenatally as well as postpartum the acronym post-birth, right? And helping them remember that. Making sure you're using teach-back methods so that you can ensure somebody understands what you're communicating with them, using those mnemonic devices. since they won't necessarily have access to any documents that your normal patients would have at discharge. And then again, discussing what happens when milk comes in. You know, as a postpartum provider, one of the things that is most important, especially as somebody is leaving county jail or is leaving prison, is to help them connect back to resources. So the Medicaid application process, making sure that if they're eligible for pregnancy care management or CMARC services for their kids, that they know how to access those and that they're given a warm handoff to those services or other home visiting programs. And WIC, really key. In terms of referring for substance use treatment, Horizons has a substance use disorder program and legal services initiative that is really focused on substance use treatment services for incarcerated women, including pregnant and parenting women, upon arrest and at any point during incarceration, including post-release. So if you have a patient where you're like, wow, we need to get her into treatment as soon as possible, call the number here, and the folks at Horizons can help, and this is statewide, help get that patient connected and hopefully diverted from a carceral setting into a treatment setting. There's also the Alcohol and Drug Council of North Carolina. This is how you can access services statewide for pregnant and postpartum folks, parenting folks, including those with dependent children, along with anyone in the general population who has a substance use related disorder. And you can visit alcoholdrughelp.org or call 1-800-688-4232, and that's a 24-hour-a-day number. So if you have somebody at 5 p.m. on a Friday, you can call that number and help get them triaged into an appropriate care. Any questions about any of that? I know we've covered a lot there.
Well, I'm looking at the chat. I just want to ask. So I know you're talking about what's in the Dignity Act. Are there any thoughts about how to add other things in? Like, it's just hard to imagine not having a way to express milk from your breasts. And I'm, I guess, is there energy for some additional changes? Or are we just kind of focusing here first and continuing to identify ongoing need? Just curious.
I think this has come up a couple of times in different ways. I think the prison, I think NCCIW is the leadership there is just not willing to consider lactation at this time. They won't even allow manual pumps in. They say it's a security risk. And so that's a no-go. And that advocacy has happened for a long time, but it's just under the current folks, that's not happening. There are county jails that I think would be willing to even allow women to pump. Also we got to think about our moms that have established nursing relationships, right? And if they're incarcerated for 2 weeks, that can really disrupt their milk supply. And so I do think there are jail administrators who would consider that, but what they need is help and support. And so, I think this is a place where the WIC lactation folks and other health department folks could really become strong advocates on support for setting up a program where at least women can pump and dump, or in other places, people have been able to set up volunteer networks where women pump and then that breast milk is brought to wherever, whoever's caring for the child.
Thanks, Erin. And there's one question. Does that include the safekeeping patients at the one in Raleigh? I think, thinking at the one in Raleigh, I don't know if you're referring to jail or prison, but I guess it applies, whoever is incarcerated, it would apply to, right? So including safekeeping. So including the safekeepers.
So safekeepers, when at NCCIW, safekeepers are kept separate from the general prison population, but that doesn't mean their conditions are better. Often they actually have less access to showers, less access to outside, less access to communication with the outside world or visitation than even a general inmate. And so safekeepers are often really isolated, and yeah, they are subject to the same. So that would be the same for safekeepers. So if somebody is in the safekeeping program and they deliver, let's say at UNC, and then if they were on substance use treatment, what happens right now is that they are weaned down over 2 weeks, which is not standard of care. Typically, postpartum women should be kept on substance use pharmacotherapy for at least a year postpartum, because the risk of relapse is extremely high during the postpartum period. And so right now, though, they are often weaned down within 2 weeks and then sent back to the county jail.
Can I add more on that?
Yeah.
You know, so for those of you that are interested in exploring more about what you could do at the local level, so, you know, their budget comes from your county government budget. So there's ways to partner with them. You know, the whole key to success and the work that I've done with, I know in Gaston County, has been, how can we provide additional services without it impacting their budget, right? Or if it's going to impact the budget, how do we work with the county commissioners to understand that the increase in funds that would be needed for that? So it's always so helpful if you can come to them with a plan that already outlines how an outside entity can help them do the work, or looking at ways to mitigate the cost for that. Because at the local jail level, you know, you don't automatically go to the state, you know, to the Raleigh just because you're pregnant. There's a lot of flux in and out at the local level. So there's a lot you can do with breastfeeding support there. But again, most local jails don't have the room. They don't have the facilities. And in my experience of being in some of them, they're not very clean either. So, I mean, there's a lot that you would have to do for them to be able to store it, much less even provide a safe area for them to pump and express. So, but again, the more you can do to try to help them think outside the box to offer solutions, the more successful you'll be at the local level.
And if I could just add to, we just recently had an inmate that delivered, and I'm sorry I said inmate, but okay, a mother that delivered. And that was, since I've been managing the jail health services, that's the first time we've had someone for their entire pregnancy. And if you want, I mean, I'm just gonna say we did an awesome job with this, but we actually she wanted to pump when she got back to the jail, and we set everything up, and it was just, it was a lot of, I don't want to say work, but a lot of coordination with the detention officers, but they worked with us. And so it was a great experience and making that happen. You know, unfortunately, she didn't continue, but it was her choice to stop pumping. She tried for about a week. And, you know, even afterwards, even after she decided to stop, I had them texting me, asking me where to find cabbage. So, you know, it was, but to Dr. Tormina's point, you know, we had a like a dorm refrigerator here at the health department. We had to take it over there, find a place to plug it in. I had to, you know, find a temperature monitor for it. We had to set up, I actually called the WIC supervisor who went out, who was really afraid to go out to the jail, but she did. And she taught her how to use the WIC pump. And so we got the officers to agree to let her, you know, keep her pump materials with her. And we kept the pump in the nurse's office, and she was allowed to clean them out, you know, to wash them herself, keep them. And so, you know, all of it the collaboration just went really well, but it was a new territory. And I explained that I had to sort of like do a huddle with the detention leadership and explain that this really, if we're going to commit to this, you know, they're going to have to make this available to her every 3 to 4 hours for at least, you know, a month. And they looked, you know, they were kind of like deer in headlights, and they said, okay, we'll do it. We'll do it. And so, and they were very familiar with this with this new legislation, and wanted to. I mean, I told them they had to let her pump. I didn't know if that was true or not, but they said, "Well, I don't know if we do or not." And I said, "Well, let's just try it." So
that's amazing. That gives me so much hope.
Yeah. And so anyway, I mean, and Adrian is our maternity supervisor for the clinic. So it worked so well for us because they bring her here at the health department for her prenatal care, and literally our OB and our mid-level. I mean, she gets the exact same treatment as everyone else, or all of our pregnant women do that are incarcerated. And the delivery went great. So she never had to go to safekeeping. And so I would be happy to, at any point, talk to anyone else who is interested in how to make this work, especially from a postpartum perspective.
That is really, I think, a great example of how local health department collaboration with the county facility really makes a difference, because one of the things that we found is that in counties where, like Union, like Gaston, and some others where there is good communication and relationships between the local health department staff and the jail, that things like this can be worked out, right? This isn't insurmountable. It is work, but it is doable. And I think that's, it's really great to hear about how that's worked, and to know that, now the next time there's a woman who wants to breastfeed, it doesn't feel so far into them, right? Like this is something that they can at least conceive of now. And I think, we've got other counties that we've heard from where jail administrators would consider it, but they're always worried about staffing. They're always worried about being overextended. And so I think that partnership with the health department is really key. Even if they're not providing the obstetric care, but providing a lot of that care management support and the, WIC support and breastfeeding support.
Yeah, but one thing to think about is if the detention staff is short-staffed and can't take somebody, because we unfortunately, it was terrible conditions to pump in. It was just that room where they see their attorney, and it is a, cinder block wall room. And, I don't know, imagine how you could have, let down your milk in a room like that. But anyway, it still was a private space for her. So, but, also I talked to the WIC lactation consultant, and asked her to talk to the patient about hand expression, because if she had her equipment there, she could express into the bottles, and that would, so that way she wouldn't get so uncomfortable if she was not allowed to pump. So, or not, if they didn't have time to take her to that room to pump. So there's a lot of things you can do. And, but they were, the detention staff, they were all just kind of, it was very new territory for them. But if in consideration for other sort of processes, one of the things that we weren't quite sure what to do with in the immediate postpartum, really 2 to 3 days, was, should we put her in a room by herself, or put her back in the women's dorm, because she needed to be, she needed things to be clean. And she had an episiotomy or laceration. So we wanted her to be able to use her peri bottle, and just for a privacy perspective. And then, and they were willing to work with us on that. We ultimately ended up deciding to put her back in the women's dorm. And as long as she was comfortable with that, and then our PA checked on her the first postpartum day, because we felt like she didn't want to be isolated. She got along really well with the other women in the dorm, and they were excited for her to come back. And so we thought that the isolation would be worse. And it wasn't it was not an isolation for any other reason than so she could have some peace and privacy. But
one of the things that we're hearing about during COVID is that, quarantine is basically the new seclusion or new solitary. What we found is that a lot of jails in particular, even though we know that like COVID isn't transmitted on surfaces or things like that, that every time somebody went out of the facility for an appointment, they were put back in quarantine for 2 weeks. And then during quarantine, they didn't have access to telephones, they didn't have access to reading material, they couldn't go to the canteen. Often they had really reduced showers and outside time, and conditions were pretty awful. And we've heard about some of those rules being in place, even though we know that they're not evidence-based anymore, right? And Anina Wilson-Merritt has done a lot of work to try to spread the word about things that are actually more effective, like masking, and to reduce that isolation. But if that really is a concern, is that isolation, either for quarantine levels or reasons or other reasons. In NCCIW, for those first couple of days, typically people are put back on the what's considered the medical ward, and for the first couple of days postpartum, and then before they're integrated back into the general population.
Awesome. So we have 5 minutes left. This is a great conversation. Erin, I just wanted to see if you were done with your slides real quick.
I want to say just really quickly that a lot of women do not get access to vaccination during pregnancy or postpartum if they are incarcerated. So particularly postpartum is a great time to offer vaccination if she's in a hospital setting. And again, you can give COVID, Tdap, and flu all at the same time, if that's the only opportunity to get that into somebody. And both pregnant people and incarcerated people are at increased risk of severe illness or death from COVID. And when you combine those two things, this is an extremely vulnerable population. So you definitely want to make sure to continue to offer vaccination. And then, yeah, just in thinking about advocacy efforts at diversion from prisoner jail whenever possible, there are community bail funds in North Carolina. And then again, those partnerships that we're talking about, and calling people on the violations and those resources.
Thank you so much. And yes, the recording and the slides will be available. Suzanne always does the great job of getting this out to everyone. And just see if there's any other announcements, then there's one more question in the chat, but I wanted to see, Suzanne, do we have any other upcoming announcements?
We do. Thank you so much, Erin. This was so wonderful. And also
terrible. Yeah.
Yeah, I was going to say wonderful presentation, but also really hurts your heart to think. It's hard for me to wrap my head around some of this stuff. But I'm in the chat. I'm going to put the evaluation link. So please do submit that for today. That really does help us as we're planning future communities of practice. And then I will also just note for our MHI states that our MHI teams that our next meeting. So we canceled our office hours for November because in December we're gathering for a year forward kickoff. So that will be an exciting time to see some of the new sites and the new direction that we're going with some of the technical assistance. So it's our standing office hours time, but we're really hoping that all the sites, all the teams are able to join this one on December 12th at noon. And then our next community of practice is December 15th, also at noon. It's the topic's building your village after baby. And we have the founder of the Triangle Doulas of Color that's going to be presenting for us. And so the registration is open for that. You can find it /about NCMHI.
I think your sound cut out. So some of you are already getting information about this, and otherwise you can subscribe to get on the listserv. We're really excited about our next community of practice as well. So I think if we can maybe stop the slides. Quick questions. Well, before everyone jumps off, I want to just offer gratitude to all of you for the amazing work that you do every day to advocate for moms and birthing people in our state. You are a gift to the moms, and it's such a joy to be in community with you. And hope that everyone has a good Thanksgiving. So back to the chat for the last 3 minutes. We did have two quick questions. Do we know the percentage of detention officers who are men as compared to women?
So I don't have the percentage in North Carolina offhand. We do know that it's way, way fewer women who serve as detention officers. We have some counties where they don't have any women at all as detention officers. So especially a lot of the smaller counties. In terms of, so COVID vaccination has been offered intermittently. There was a really poor rollout of COVID vaccination amongst incarcerated folks across the United States, including in North Carolina, where there was, especially at the beginning, some real delays in getting vaccination to incarcerated folks, particularly pregnant people. But now it kind of depends on when vaccination, when folks are available to provide vaccination, if you happen to be there at the right time, you know, and unless you got arrested with your vaccination card on you, there's often no record, there's no easy way for folks to see if somebody has been vaccinated or not. And so it's kind of all over the place and not very consistent from county to county or even day to day. So.
Thank you. Again, thank you everyone. And we've had new folks here and glad that you're here. Hope everyone has a really awesome rest of your day. Erin, thank you for such an important presentation. I learned a lot and I appreciate all that your team is doing. So thank you, and everyone take good care and be well.
All right, bye.
Thank you.